Welcome, everyone. Thanks for joining us today. My name is Jillian McConnell, and I'm the Knowledge Mobilization Lead with Brain Exchange. The webinar we are proud to be hosting today is part of the webinar series on the clinical guidelines on substance use disorder among older adults, which is being offered in partnership by the Brain Exchange and the Canadian Coalition of Seniors Mental Health and Behavioral Sports Ontario. A few housekeeping items to begin, to address before we get underway with today's presentation. We do suggest that you connect only through the computer. You should not be on your phone necessarily for this webinar. For those of you who do not have computer speakers or are experiencing some challenges in receiving the audio via computer, then we do advise that you join via the teleconference line provided in the instructions. But again, we ask that you use only one option for audio, as using both the computer speakers and the telephone will cause some feedback or echoing. On the right-hand side of your screen, you'll see a chat pod, and that's where you can communicate with my colleague Karen and I during the presentation, and where you can send your questions during the Q&A portion. If you're having technical issues, then we ask that you respond back to the flyer or the invite that was emailed to you, and Karen should be able to assist with that via email. And we'll be leaving some time at the end of the webinar for a Q&A period. You will be able to ask a question by typing into the Q&A box or the chat box on your screen. The presentation itself is being recorded, and the resources and the recording of this session will be posted on the Brain Exchange website, and a link will be shared as well with you. So at the end of the webinar, we'll be, as I said, sending out those recording details, and that should be hopefully within the next few hours. So, and finally, the webinar today is scheduled to be 60 minutes in length, and our presenter will speak for about 45 minutes or so, and then we'll have the last 15 minutes at the end for some Q&A and discussion. And I do ask that people refrain from asking questions in the chat pod until the end of the presentation portion, unless, of course, it's technology related. And then please email Karen, as I stated earlier. Okay, so now that the technical aspects have been taken care of, it's my pleasure to introduce our topic and our presenter. So the title of today's session is The New Canadian Guidelines on Cannabis Use Disorder Among Older Adults, and features our presenter, Dr. Jonathan Bertram. So Dr. Bertram is a focused practice addictions and pain medicine physician currently practicing at CAMH and at the Bowmanville Family Health Organization. He is a member of the Board of Directors of the Ontario College of Family Physicians, an older adult addictions consultant to COPA, which is a community outreach program in addictions, under Reconnect Mental Health Services in Toronto, and a clinical lecturer at the University of Toronto. Working at local, regional, and provincial levels, his work focuses on improving the health of vulnerable populations struggling with substance use and mental health comorbidities, in particular improving service delivery and access. He has special interest in working with older adults, Aboriginal affairs, and mental health addictions in primary care. So on behalf of everyone on the line, I welcome you, Dr. Bertram, and turn the floor over to you.
Thanks, Jillian. I hope everybody can hear me, and I know I've got a certain amount of time to put this forward to you so that we can maybe have some questions at the end. So I'm going to get going. Thank you for that introduction. So this is a presentation on the older adult guidelines around cannabis use disorder, but this is part of a larger initiative that addresses substance use disorder in older adults. Before I start, I'd like to make a few disclosures and acknowledgments. Just to disclose that I don't have any relationships with commercial interests, no potential for conflict of interest. The funding for this work that was to the Canadian Coalition for Seniors Mental Health was from Health Canada's SUAP initiative, Substance Use and Addictions Program. The working group members were carefully screened for any conflict of interest, and working group members did receive an honorarium for their work on the project. As an overview, what we're basically going to try and cover here is, after going through acknowledgments, providing you some context as far as defining substance use disorder, not wanting to take for granted that many of you, while working in the setting of helping people from the standpoint of their interest or use of cannabis, may want a clearer definition of substance use disorder. And then trying to shape that in the setting of substance use amongst older adults, because this is still a relatively a newer phenomenon, one that I think has gotten a lot more attention and that we've had a bit more fulsome discussion about over the years from when funding for this initiative first came about, but still nevertheless an emerging topic. and then trying to sort of frame the findings from our work through the scope of the Guidelines project broadly, relating that to the implications and patterns of use amongst older adults in the setting of cannabis. And then, of course, getting to the meat of this presentation, the guideline recommendations. So as you can tell there's 5 pieces on the overview that are really constituting a much smaller part of the presentation. So I'm going to try and be nimble with that part of the presentation. So just acknowledgments to, first and foremost, our project director and project coordinator, Claire Checklin, and Indira Fernandez. They really were very much the people who pulled a lot of this work, if not all this work together. And we benefited greatly from the oversight of our steering committee, and of course the work was supported by the Canadian Centre on Substance Use and Addiction as a partner with CCSMH, Behavioral Supports Ontario, their Substance Use Collaborative, a number of institutes and hospitals around Ontario, and our reviewers, Dr. Michael Beasley, Dr. Kim Carres, and Dr. Mel Kahan. And of course, Health Canada did support our Substance Use and Addiction program, did support our initiative through the Substance Use and Addictions program, and it's important to note that the views expressed herein do not necessarily represent the views of Health Canada. And the people who work directly on these guidelines, the cannabis guidelines, included myself, my co-chairs, Dr. Amy Porras and Dr. Dallas Seitz, and the working group members included Dr. Harold Kalat, Dr. Ashok Krishnamurthy, Jason Nickerson, Dr. Mona Sidhu, Dr. Andrew Smith, and Rand Teed. And this was very much a fulsome process in terms of both trying to identify what would be practical, what was sort of challenged by what wasn't in the literature, and being able to translate that into guidance for people who nevertheless have to answer these questions, for the many individuals who are asking about cannabis, no doubt reflected in the number of people who were interested in this webinar. The context for this talk and for this initiative is, again, very much in the sort of emerging narrative around substance use in older adults, and no doubt influenced by this report by the CCSA, Improving the Quality of Life, Substance Use, and Aging, a report that came out last year, 2018, through the Canadian Centre for Substance Use and Addiction. I had a wonderful opportunity to contribute to this in collaboration with David Kahn, who was the chair of our steering committee, and the chair for the benzodiazepine working group as well, and talking about older adults and the adverse effects of substances. Canadians have several misperceptions when it comes to substance use among older adults, and in a lot of ways we touch on that in these guidelines in terms of how that shapes how a person might come asking questions to their healthcare provider, to their family member, to their caregiver. Some don't think it's an issue at all. Others believe it's too late to improve the quality of life of someone who uses substances in older age. And so trying to deconstruct that narrative when it comes to screening, when it comes to thinking about therapeutic options, and obviously when we talk about prevention. And why try to get somebody to quit smoking after 50 years? Isn't the damage already done? And trying to give you a sense with what we focus on in these guidelines that recovery is very much central to treatment when we talk about substance use disorder and addiction broadly, and certainly
put my headphones in and leave you.
Certainly just as relevant when we talk about cannabis use disorder. And why is this so important? Why have we really emphasized this context? Because substance misuse in older people is certainly a rising, more prominent phenomenon. The baby boomers generation are the population that are at the highest risk, and in a lot of ways it's already begun to present itself in terms of adverse events, in terms of presentations that emerge, and as a result there's very much a call for action, as evidenced by this Guardian article that we often cite when talking about the state of older adult substance use disorder. And this is not confined to any one region. This article focuses on what we're seeing in Europe, in the States, and this is not a new phenomenon, as much as I have spoken a few times to it being emerging. This is a 2011, an article that's based on a 2011 report. So that presentation and that concern is very much in the setting of people encountering substance use and people encountering it in a way that fits into what we call the continuum of substance use. So people are not developing substance use disorders at any stage of life, but certainly when we talk about older adults, because they want to create complications. When they start out using, they use because it provides them benefit. And something that we try to touch on in these guidelines that at first we were hesitant to address was the clinical indications. But what we started to appreciate as we both looked into the literature and more importantly tried to see how practically this could help colleagues was medical indications. Not because this is a guidelines on the medical use of cannabis, but certainly with the context and intersection of cannabis use in the setting of so many different clinical indications, many people would come asking you about cannabis because of reasons that you could categorize as medical. But with that story that starts out with substance providing benefit, when we start to talk about a person's story turning into something far more unfortunate, that eventuality, especially when we talk about use disorder, doesn't happen right away. It often starts to change and morph into what we call substance misuse. And as a person starts to use more often, use through different routes, use more of that substance, the beneficial use starts to look like misuse. And at that point, a person begins having to balance for themselves the benefits and risks of their use, not always with the greatest insight, and something we won't focus on at this presentation, but certainly part of the science that we know that an insight into that balance actually starts to wane as that person advances further along the continuum. And usually when they are seeking help, but not always, they are encountering the stage of what we call use disorder. And that is where, at that point, the consequences of their use are apparent. And that consequence is in the setting of mental health, in the setting of physical consequences, but almost always psychosocial. And this is often an issue for many people, but of graver concern when we start to talk about older adults, especially with regard to increased tolerance, with regard to physical withdrawal, and loss of control of their use. So when we looked at the literature, when we tried to think about cannabis use disorder in the setting of this continuum, we really tried to adhere to the framework under the DSM-5 for substance use disorder. And if you'll notice there, problems with substances have been categorized differently over the years. And certainly in my practice, we've moved from the DSM-4 framework of looking at dependence, looking at abuse, and in fact looking at them separately in a lot of situations. And now when we talk about problems with substances, when we talk about addiction, we're looking at it through the lens of substance use disorder, which is very much an amalgamation of abuse and dependence. And looking now at a person's use disorder along a spectrum, so not just sort of looking at a simple threshold that a person clears to qualify as having substance use disorder, but looking at mild, moderate, or severe use disorder based on the number of criteria. And in addition to that amalgamation, there's also one key feature that we've begun to acknowledge more, that we ask about, and that we look at as a key feature of a person struggling with use disorder, which is cravings. And if you look at the very bottom there, you'll see that cravings are highlighted. And cravings are a word that probably don't do full justice to what a person experiences when they, consciously or subconsciously tilt or lean towards a substance. And so urges, a lean, a thought, probably also falls under that umbrella. And all of that helps sort of set the stage for that diagnosis of use disorder. So it's with that in mind that, and with that framework in mind, that we really started to look at what evidence was there for substance use disorder, and more importantly, cannabis use disorder amongst older adults. And we tried to look at that in the setting of a few pieces. Increased vulnerability to the effects of substance use due to unique physiological, psychological, social, and pharmacological factors. The frequency and longitudinal use of cannabis and what kind of impact that might have on a person's risk for cannabis use disorder. But we also talked about risk in the setting of comorbidities, cognitive impairment, polysubstance use. And we openly acknowledged that we're addressing this literature and coming to recommendations around management, around prevention, screening, education even, in a setting where use disorder is still under-identified, still understudied for the population in general, and probably even more so when talking about older adults. And a big part of that is, unfortunately for worse, and hopefully something that will change for the better because of the stigma that surrounds use disorder. So the scope of this guideline project as a whole, which, as I mentioned before, very much under the guidance and infrastructure of the CCSMH, was funded by the Substance Use and Addictions Program, SUAP of Health Canada. And it was to broadly create 4 guidelines for the prevention, assessment, and management of substance use disorders amongst older adults for alcohol, benzodiazepine receptor agonists, cannabis, and opiates. And this is the 4th of the 4 guidelines that are being presented here as a webinar on Brain Exchange. The approach in looking at the evidence, in looking at the literature for coming up with these guidelines was GRADE. So the GRADE approach was utilized looking at both quality of evidence for each recommendation and the strength of each recommendation. And so as we go through the recommendations, what you will see is high, moderate, or low quality of evidence based on what we were able to find or couldn't find. And then based on our discussion, based on the experience of the group and the feedback from reviewers, coming to a notion of what strength that recommendation should carry. And in some cases, this was irrespective of what the quality of the evidence was at this point. In some cases, we had an alternative rating of consensus where there wasn't any empirical evidence, but we felt it was quite important to include because of the impact that it would have on practice. Okay, so to sort of set the stage for these guidelines, maybe establishing some real basic definitions around cannabis itself. So the cannabis that we were thinking about and looking at was very much what most people kind of regard when talking about cannabis or marijuana, a plant that contains hundreds of compounds, including cannabinoids, which act on the endogenous cannabinoid or endocannabinoid system. But in particular, what we were considering, especially when we started to talk about adverse events and indications and how that interacted or intersected with people's own motivations to ask about and use cannabis, were cannabinoids. Two in particular, delta-9 tetrahydrocannabinol, THC, and cannabidiol, CBD. And these were the two that were the most available in the literature. And these cannabinoids bind to receptors, CB1 and CB2. CB1 is located centrally in the brain, and CB2 is located primarily peripherally and on the circulating immune system throughout the body. So THC binds the CB1 receptors, and THC is often responsible for producing that high or sense of euphoria that many people remark when using cannabis. THC is also vasoconstrictive to blood vessels in the heart and brain, and so we did make note of the association of risk with cardiovascular events, including stroke, cardiac arrhythmia, and myocardial infarction, not just intuitively, but in terms of what was of note in the literature. CBD binds primarily to CB2 receptor sites. CBD binds weakly to CB1 receptors and may interfere with the binding of THC. And in many cases, and certainly people who have tried this, people who you have worked with, people I have seen, might note a resultantly lack of euphoria and reinforcing effect. So the cannabinoid composition of the cannabis plant itself is not as simple as these two cannabinoids. It's quite wide-ranging, and it certainly varies by strain. And the landscape, when we talk about both recreational and medical cannabis, has quite a ways to go to properly characterize and categorize, simply for consumption, let alone for research, what a person is actually taking in. Some are higher in CBD, and others contain more THC, and so we have to acknowledge that as a result, a person is vulnerable to a variety of psychosomatic properties. So when thinking about those basics, it's very much in terms of how they associate to both adverse events and indications. And on a high level, what certainly seems to stand out more, not that they are exclusive to all instances of cannabis use, but what does seem to stand out more when we talk about adverse events are motor vehicle collisions, cannabis use disorder. Those aren't the only two, but certainly those are the most prominent in the literature. But long-term negative psychiatric effects like depression, anxiety, worsening post-traumatic stress disorder symptoms, panic attacks, and even suicidal ideation attempts, and even completion rates in some of the literature, although as you'll see in our recommendations, we did not lean on all of the adverse events, but they have been in what we were able to find. And non-fatal overdose. So, the narrative when it comes to overdose in the setting of substance use has very much been characterized by fatality when we talk about opiates, by morbid and in some cases mortal complications when we talk about alcohol, and even benzodiazepines, although I'm going to defer to what was covered in those presentations when speaking to that. But when we talk about cannabis, we think less in terms of that. We do, however, need to remember that it can still result in adverse events, and often it's cited that in certain jurisdictions where cannabis was first introduced, first legalized, there was some association with adverse events, especially in relation to ingested edible cannabis derivative products, because essentially a person didn't know how much they were getting when they would take cannabis into their system in edible form, for instance. And so they might still suffer from cannabis intoxication without sort of taking that conservative approach and sort of unsuspectingly suffering an overdose. And in addition to adverse events, we didn't shy away entirely from talking about the opposite, indications. What benefits could there be? Mainly because, and I'm going to touch on this, so many of the individuals that we were thinking about, both in terms of our colleagues, but most importantly in terms of our clients, our patients, those people who are asking questions about cannabis, are asking because there is some thought to the medical indication. And medical evidence that does exist for certain cannabinoids shows that there may be benefits, but really only a small number of clinical indications. Chronic neuropathic pain, nausea and vomiting due to chemotherapy, seizures, spasticity and multiple sclerosis, stimulation of appetite in patients with severe weight loss due to AIDS and possibly cancer. And I do have to underline here that the sheer quantity of evidence even supporting these is not as significant as it's sometimes made out to be. But there's obviously a reason why people are still asking about that, and people, including professionals, are still thinking about how it might be applied. The pace and scope of cannabis research may require clinical recommendations, such as those below, to be updated and modified more frequently in order to stay current. And we really tried to limit how we spoke about indications in the setting of counseling. We did not want to begin to wade into medical indications for cannabis use in the setting of anything other than counseling and education, because this is a cannabis use disorder guideline. So the questions about cannabis, whether that's adverse events, whether that's indications, and the the idea of this emerging narrative is not happening in a vacuum. It's very much happening in a setting where we are seeing more and more people use cannabis as the years and in fact the decades go by. And this is a graph that shows people over 50 who used cannabis in the last year reporting increasing rates. And if you'll notice that rate of increase begins really sort of more around the 2000 mark. And so it isn't necessarily that we were dealing with this sudden spike or this sudden interest in cannabis coincident with the anticipation of legalization in 2018. In fact, it's not specifically correlated. Certainly, there's some thought that it's not all that much of a coincidence that around 2001, when medical cannabis became legal, that we started to see an associated increase. And certainly this graph sort of speaks to that narrative. And with increasing numbers of people using cannabis, asking about cannabis, wanting to try it, we're left with more challenges. And so what are the cannabis challenges? Well, physicians have different views on cannabis, and providers in general have different views. Prescribers especially are in a position to make that available or not. Patients tend to have mixed information about cannabis as well, whether that be from their provider or through other means. And often, in many situations, it's through other means. And that was a big part of why we thought we needed to really invest in the education aspect of these guidelines. And there are multiple narratives, multiple reasons why people are coming and asking, why people are seeking out information, and unfortunately, it's met with limited evidence based on what's in the literature on cannabis and cannabis use disorder among older adults. So what are some of these multiple and changing narratives? And as you can see there, the tie-dye graphic thinking about those people who use cannabis, probably used them in greater numbers back in the 60s, and are maybe now thinking of returning to it, or as we often refer to when we talk about older adults and older adult substance use disorder, have aged into continuing to use it, and whether or not we need to help them, speak to them, even work with them around monitoring their use if it isn't already a problem. And in the top right graphic, there's probably the more, I guess, traditional, or maybe traditional is not the right word, but modern notion of a cannabis user, someone who's using, smoking a joint, and sort of that traditional means of use, which of course there are many more modes. And then that last graphic at the bottom is, a gentleman who's got a bottle of alcohol, who's even got some prescription pills if you look closely. And that's a graphic that speaks to the intersection, not just with these narratives that you see on the slide, but other narratives, narratives that really illustrate an intersection of use and an intersection of ideas around where cannabis fits. So our group did get together in advance of beginning to publicize these guidelines over the last year to talk about the intersection, in some ways very much the unique intersection between medical and recreational use of cannabis at a time when we are very much still dealing with and still trying to not just recover but manage the consequences of the opiate crisis, people's questions about being able to get off of opiates, and persisting questions about what else to do for their pain. And this seems to be happening at a time when another substance, for completely different reasons, is also part of the older adult narrative, and that's alcohol. And alcohol is very much a part of our social normative. It is something that, despite being the most prevalent addiction, we have probably destigmatized in a lot of ways as a substance in and of itself. And people's own sort of ideas around why they use alcohol and when they use alcohol, if you begin to ask them about why they're asking about cannabis, could sort of fall less into that more, clinically categorical narrative of I need it for pain and I need it for anxiety, and more around, well, I just need it to relax, which is not all that different from a person talking about, maybe having a few beers or a few glasses of wine or sherry at the end of the night. And in fact, as we know about older adults and older adult use, that's something that they're perhaps engaging every night. And so frequency of use is very much a pattern of use that is tied to older adults more so than any other age group. And that gray between those two substances and cannabis also blurs the lines between medical and recreational use. And so a big part of why we decided to at least address clinical indications was because of that. So this has implications for practice, decisions based on changing social norms, seeking cannabis through the retail and black market, accessing based on convenience, all because people are very much kind of graying recreational and therapeutic motivations for cannabis, often not intentionally, but simply because they are seeking answers to difficulties or challenges that they're coming across. But perhaps as we talk more about this, we can reduce stigma rather than feed into increasing stigma. Regardless, it leaves the provider with a number of challenges. Not knowing where to go in terms of literature, not really having any well-established guidelines off of which to work, a lack of findings on the objective consequences of cannabis use, and as a result not really being able to address the ambiguity that their client or their patient or their family member is coming to them with. So I'm going to touch on the guidelines now. If you notice there, it's categorized into prevention and education, assessment and recognition, and management. And we're going to go recommendation by recommendation, but I am going to spend a bit more time on certain recommendations over others. So the first recommendation was, again, under the category of prevention and education, that cannabis should generally be avoided by older adults who have a history of different categories of comorbidities. So what we found, reasonable, moderate evidence for, but felt we need to make a strong recommendation in favor of, was avoiding cannabis in the setting of people who've got mental health disorders, problematic substance use, or substance use disorder. We also felt that cognitive impairment, cardiovascular disease, cardiac arrhythmias, coronary artery disease, unstable blood pressure, or impaired balance were conditions that really should give great pause as to whether or not you're going to go forward. Now, keep in mind the language we kept here was generally, and we really tried to engage the conversation around indications in a way that we respected what we knew about what was in the evidence. But at that point, a person should be thinking about going to a specialized provider, a provider first who's got a better sense of clinical indications for cannabis. But in the setting of someone asking about, I don't know, going to the Ontario Cannabis Store or getting something from the cannabis dispensary because of more casual ideas of how it could help them for clinical reasons, if they've got a background that falls into either of these categories, a general directive would be to avoid. We also thought that it was important that when making those types of recommendations, clinicians should be aware of the current evidence base on the medical use of cannabis, understand that that is relatively limited, and that most derivative products have actually not been approved as therapeutic agents by Health Canada, with the exception of 2 pharmaceutical-grade cannabinoid products. The common signs and symptoms associated with cannabis use, cannabis-induced impairment, cannabis withdrawal, cannabis use disorder, and common consequences of problematic cannabis use should be things that a clinician is aware of before providing any kind of counseling around cannabis use, certainly in a recreational setting, but also in a medical. And the potential adverse effects of cannabis use in older adults can include changes in depth perception, risking balance instability and falls, changes in appetite, cognitive impairment, again, cardiac arrhythmias, anxiety, panic, psychosis, and depression. And mental health disorders, which are commonly comorbid with cannabis use disorders, such as depression, anxiety, and schizophrenia, psychosis, are conditions that the clinician should be aware of before they begin providing counseling around whether or not and how a person should use. The grade for these recommendations was also fairly robust, moderate to high in terms of evidence, especially evidence around medical use of cannabis and the signs and symptoms of those cannabis-related conditions was quite high. All of our recommendations were strong as far as really thinking that clinicians should have that education. And in order to support the retention of information, clinicians should provide education and counseling with regard to cannabis and cannabinoids to older patients and their family members, caregivers, both verbally and in writing. So this is not something that we gleaned per se from the literature, but in thinking about just those first 2 recommendations, how much really needs to be covered, how much responsibility there is from an education standpoint. We couldn't imagine someone simply coming away from that with a casual conversation, and in many cases by themselves. Having family member or caregiver around and possibly having materials on hand so that they could reflect and go through some of this in an organized way was reasonable. Clinicians should counsel patients, caregivers, and families to be aware that older adults can be more susceptible than younger adults to some dose-related adverse events associated with cannabis use. And here the evidence is very high. The strength of the recommendation was strong, and that was especially in relation to the susceptibility to cannabis overdose, the vulnerability to some of the pharmacological effects of cannabis, especially when we start talking about modes of use that don't give an immediate effect like edibles. In keeping with that, clinicians should advise patients, caregivers, and families about potentially increased risks, especially when we start talking about higher potency THC extracts or higher potency strains of cannabis when compared to those with lower THC content. Now, while the evidence on THC potency specifically as it pertains to risk and adverse events is there, it is generally low. And so the strength of our recommendation was still strong because and I will touch on this in a few slides, what we see comparatively when it comes to THC-related adverse events as opposed to CBD. And this is a table looking at what we were able to find in the literature. This is, again, low quality of evidence, so it was often in the form of case reports, maybe low-quality observational studies of things like dry mouth, dizziness, drowsiness, psychoactivity, perceptual alterations that could interfere with depth, headaches, changes in bowel habits, short-term memory impairment. These were all issues in the setting of acute adverse effects from THC, but headaches, changes in bowel habits, short-term memory impairment, this was seen even with chronic THC use. So even if there was a tolerance, that was achieved after a while. Attention impairment, palpitations, tachycardia, postural hypertension, appetite changes, falls, nausea, vomiting. These were also acute changes seen with THC use, but falls and nausea, vomiting, especially in the setting of cannabis hyperemesis, were also associated with THC in the literature. Important adverse effects of chronic use of THC that were not included in this table included chronic bronchitis, but also some evidence, albeit low quality, of impaired work or school performance, and something that we'll touch on with the driving guidelines, a greater risk of accidents at work and driving. As you can see, the adverse effects of CBD in terms of what could be found in the literature were much less, both in terms of there not really being anything in the setting of chronic use, and that's something that we termed unknown at this stage. Clinicians should advise patients, caregivers, and families of the risks associated not only with potency, but with different modes of use, and counsel patients on these risks. So risks associated with chronic use of inhaled formulations, whereas when dealing with topical cannabis, especially with CBD-only products, there didn't appear to be as much noted in the literature. What we were able to achieve a great deal of unanimity on, even though there aren't as many sort of reports, were around illegal synthetic cannabinoids, so K2 and spice, and especially thinking about those people who might be using illicitly, who might be using through a street supply. These have the potential for serious harm. Using these products can lead to severe health problems such as seizures, irregular heartbeat, hallucinations, and in rare instances, death has even occurred. And the concern with illegal synthetic cannabinoids are not just them in and of themselves, but what they can be laced with. And with all the talk about the opiate crisis, those concerns around fentanyl or heroin as well. And clinicians should educate patients on the risk of cannabis-induced impairment, especially if the patient is cannabis naive or titrating to a new dose. It is recommended that the starting dose should be as low as possible and gradually increase over time. So thinking about those adverse events that we'd sort of put before you with that table, thinking about the risks that are reasonably established as far as the potency of THC. We thought quite important that a very conservative approach to initiating any dose of cannabis, going as low as possible and then slowly bringing that up was not only prudent but appropriate. This is often the directive when speaking to any person of any age, but with older adults and their vulnerability to some unexpected events, this was particularly relevant. Clinicians should counsel patients on the potential long-term effects of frequent cannabis use, including respiratory problems, precancerous epithelial changes, and cognitive impairment. Patients should also be counseled on the risk of exacerbation of mental health conditions with CUD, especially when high THC strains are used. So we were careful with our language here because, as you had seen before, evidence of chronic effects or adverse effects of chronic use were harder to really nail down in the literature. But in terms of those downstream outcomes like respiratory problems, like cognitive impairment, precancerous epithelial changes, the evidence was moderate in terms of quality. It's reasonable to counsel that equally what we know, but more importantly what we don't know yet, lends itself to greater risk. And so counseling people not only on, sorry, was that?
Oh, you're okay, Dr. Bertram.
Okay, counseling people on what they are very much sort of vulnerable to over the longer term is quite important when they are embarking on this journey in a lot of situations with their cannabis use, regardless of the category we're placing that in. We also were a bit more detailed and a bit more tangible in terms of safety in the setting of driving, and we pulled this from both transport and occupational guidelines. So we did recommend that clinicians advise patients, caregivers, and families that cannabis may impair the ability to safely drive a motor vehicle for up to 24 hours. There's a lot of literature that looks at a range of anywhere from 6 to 24 in terms of safety, but we really thought it was important, especially in the absence of older adult-specific literature, to really err on the side of caution with this range, and that was the reason for placing 24 hours as the caution there. The use of both cannabis and alcohol together can result in synergistic impairment and can increase the risk for driving and should be avoided. And this may seem self-evident to you, but the increasing evidence of cannabis-infused alcohol, for instance, was one of the reasons why we thought, especially in a recreational setting, people's interest in trying both was something we thought they needed to be very prudent about. And it is dangerous to ride as a passenger the driver who has used cannabis within the previous 24 hours. So I'm mindful of the time, and I'm wanting to touch on a few important pieces around assessment and management. So one of the things that we did want to address was around assessment of and screening of cannabis. And this recommendation looked at the use of non-medical and medically authorized cannabis and cannabinoids, illicit synthetic cannabinoids, as well as tobacco, alcohol, and other drugs were a strong reason, we thought, for a person to be screened and if they for cannabis use disorder. And if they were going to be screened, we really recommended the use of the cannabis use disorder identification test. That is available. It's an open access tool, but it very much draws from portions of the criteria. I want to emphasize, though, that the QDIT is not a diagnostic tool. It is very much a tool that that indicates a reason for a person maybe being indicated for an assessment. Clinicians should be aware that the diagnostic accuracy of some of these screening tools are variable when we talk about older people, because a lot of what older people have to deal with in terms of problems, consequences, that may be more psychosocial, could be attributed to cannabis use disorder, in some cases erroneously. So that a person does have to have a bit of skill when making that assessment, and for that matter, even interpreting the screening data. And then I'm just going to jump over to the pieces around withdrawal and hyperemesis. So we thought that clinical assessment of cannabis use disorder in older adults should evaluate the signs and symptoms of cannabis withdrawal, with consideration that the rapid reduction or abrupt discontinuation of cannabis use may be associated with withdrawal symptoms. So withdrawal emerges between 1 to 3 days of abstinence, and it can peak between 2 to 6 days and can last for much longer, in some cases up to 2 weeks. This is often as a result of a desensitization and downregulation of the CB1 receptors. And that begins to reverse over the time period that I noted, and in some cases can last and can slowly attenuate over 4 weeks. When assessing patients, clinicians should also be aware of the risk of cannabis hyperemesis syndrome. So I don't want to say the reverse of cannabis withdrawal, but sort of on the other end, when we talk about adverse events with cannabis use, is when a person is continuing to use and certainly using too much. They can have associated nausea and vomiting. So we often see this in settings of chronic cannabis use, higher potency preparations, especially when talking about THC. And in those settings, chronic heavy use of cannabis can lead to recurrent episodes of severe nausea, intractable vomiting, abdominal pain. And in most cases, that person is going to relay to you a story that involves that and involves relief of those symptoms after taking a hot bath or a shower. The resolution of the problem when cannabis use is stopped is sometimes unbeknownst to them or not obviously apparent to them. And while we do have some medications that we use in the emerge, like ondansetron and haloperidol, these don't really come with great evidence. A lot of this is a subject of emerging research. We did believe that the use of the screening, brief intervention, and referral to treatment model that is strongly evidence-based for alcohol but low in evidence for other substances was applicable, and it was a strong recommendation when taking an approach to cannabis use disorder, as it should be for all other substance use disorders in the group's opinion. And we thought that especially in the setting of cannabis use disorder being so early, as just an issue that requires treatment in the setting of addictions and substance use disorder, peer support programs should be considered for individuals with CUD, but evidence-based therapies with moderate evidence that we recommended strongly, like cognitive behavioral therapy, MI, mindfulness-based relapse prevention, motivational enhancement therapy, contingency management, very much standard tools for treatment, be considered when talking about cannabis use disorder. There are currently no established pharmacological treatments that have been demonstrated to be safe and effective for either cannabis withdrawal symptoms or CUD, but we did acknowledge in our narrative that there is low-quality evidence for certain medications, gabapentin, oral, off-formulary, off-label use of N-acetylcysteine, NAC, has been used, but we did emphasize that specialist providers with high degree of experience were people you very much wanted your client, your family member to be evaluated by before being managed. And there was limited studies on abalone for helping with withdrawal management.
Did you eat?
Okay, so I'm looking at the very limited time. I'm noting here that we also sort of acknowledge residential treatment. I'm going to acknowledge the documents that we did refer to, that isn't the exclusive list of references, and the non-medical cannabis clinical tool with the Center for Effective Practice. Again, those are our recommendations, and maybe open it up to questions now.
Wonderful. Thanks, Dr. Bertram. I know you had a rush at the very end there, so I appreciate you allowing some time for questions. I do want to just make sure that I've seen some questions come through about whether access to the slides will be available, and I want to just note that yes, the slides will be available as well as other resources through the link at the end of the event, so in the next few minutes, and then you'll also receive, all participants will also receive access to the slides and the recording of this webinar later on this afternoon. So I just wanted to make note of that. If you'd like to ask any questions, you can do so by typing in the Q&A box. And we've already noted that some people are already asking away here, so I'll do my best to get to some with the time remaining. In terms of a copy of the guidelines, I think that would be one of the first and foremost questions. How can people access the guidelines and when?
Yes, so it's good that I got this directive before. So the English version should be online within the coming 2 weeks. I'm reading this directly from our project coordinator and director. The French version,
Get out of my way.
Probably in February.
Okay, thank you. And just to note, for those that aren't already muted, if you don't wish for us to hear any background conversations, to please press star 6 to mute your line, please, because we're hearing some background noise. Thank you. A couple of other questions, hopefully. What are your thoughts on the use of cannabis related to responsive behaviors, Dr. Bertram?
Well, I knew you were somewhere.
Sorry.
Jen, excuse me, we're having some background noise. If you could just press star 6 on your line to mute, please.
Did I offend you? I'm sorry.
Sorry, I didn't hear that. Could you
Sorry.
say that my way again?
The use of cannabis or CBD with respect to responsive behaviors.
So, it's, and the slide was sort of very tame and in many ways very simple, because that's kind of the state of the evidence at this stage. It hasn't been well studied. It doesn't mean that there isn't, reason behind why some clinicians might employ that, but we really sort of tried to emphasize that the most important thing is to be able to go to people with experience, go to people with expertise in terms of assessing the condition in question, and then proceeding in a way that's prudent, observing what we are starting to know about those adverse events, because we still don't have a clear idea of indications.
Okay. And keeping along those lines, someone is asking about the use of nabilone as an alternative to address behavioral symptoms. What are your thoughts on that?
So, nabilone is a nabiximols that's been studied. It does show sort of third-line evidence for some forms of neuropathic and centralized pain, and in some cases with nausea, vomiting, and there's certainly effect. That a lot of people will point to the fact that it's a THC sort of compound. It's a THC analog, and the concentration of it is very, very low. But it's probably, the same directive applies. As much as there's a bit more evidence in certain areas when it comes to nabilone, certainly for me with my practice, I proceed very carefully with that. We do use it on occasion with cannabis withdrawal as well, but this is off-label use, and at this stage a very low level of evidence.
Thanks. Also, just you noted in a few of your slides that where the evidence wasn't necessarily strong just because of the lack of research that's taking place right now. Do you anticipate more studies in the future having to do with specifically older adults and the use of cannabis now that it has been legalized?
There are definitely going to be, as far as I'm concerned, or as far as I know, there's more studies coming along the way. I think the area where there's more to kind of organize ourselves around is to what extent is this going to be industry-driven? To what extent should this be a collaboration between academia and industry? Certainly even with, CAMH, we're putting out a cannabis course, and we're even having to think about that in terms of to what extent is education going to be in part supported by industry, not because we would prefer to have that, but because we, I think, need to get all of our talents together in order to make gains in this area. So I do think studies will be done. The question is by who, in what sort of partnership, and most importantly, how can we interpret that information?
And this is an interesting question. And so how do you ensure that clinicians play their role in prevention and education while cannabis is widely used and available to the general public now?
So every person that I see, and when I'm talking about my patients, so as a clinician, my way of engaging and interacting with that exercise is to tell them, look, this is what I know, this is what I don't know. If you're asking for my recommendation, I'm going to tell you what it is that we should do next. But if ultimately that's not a recommendation that you are comfortable with or that you prioritize, then I'm not going to not be involved in your cannabis use. I want you to tell me how much you're using. I want you to tell me what your experience is. And even if I'm not necessarily prescribing that directly or, sort of endorsing it with a recommendation in the setting of something recreational, I want to treat it as if it's something that you are being prescribed. And that way, if things are happening, if there are adverse events, if there are issues, both acute or chronic, we can be involved in the assessment and we can be involved in the education, and that mindfulness remains.
All right. Well, unfortunately, I'm going to have to leave it there. I know that there's a lot of other questions, so I'm sorry we weren't able to get to them all. I want to thank our presenter, Dr. Jonathan Bertram. It was such a pleasure to have you with us today, Dr. Bertram, just to share your insight and your experience. And I know that these guidelines are such an important component to education and prevention as well. So thank you for that. Thank you, of course, to our participants for your questions and comments. It always makes for a really engaging webinar when we have that exchange. So thank you so much. So the links and the recording will be posted online, as you can see. As well, I also want to mention that there will be an additional online survey that will be sent to you when you receive that recording link as well. So I invite you to take part in that. I would like to thank Behavioral Sports Ontario for their financial support to this webinar, as well as Behavioral Sport Ontario's Substance Use Collaborative for sparking this initial conversation. And of course, a special thank you to the CCSMH, not only for their financial support for this webinar series, but also for their very, very important leadership in the development of these best practice guidelines. I know Dr. Bertram mentioned it in the beginning of his presentation, but just to reiterate that acknowledgement. So as I mentioned in the introduction, this is one of a series of the webinar series of new clinical guidelines on substance use disorder. So please keep an eye out for some information with respect to our next webinar, which will be scheduled to take place in January likely. So keep an eye out for that. If you're a Brain Exchange member, you'll receive notification with the registration. And also on behalf of the CCSMH and Brain Exchange and BSO and all of our partners, I want to wish everyone a happy and healthy holiday season, and we look forward to seeing you again in the new year. So all the best, everyone. Have a great day. Bye-bye.
All guests have been muted.